Hello and welcome to TMA's Ask the Doc webinar series. I will be your host tonight. I am Rachel Bromley, TMA Senior Manager of Patient Education, Support, and Advocacy, and I am wearing red today in honor, okay, of course it would be backwards. In honor of Rare Disease Week, we are on Capitol Hill. And I actually recently got off the train. I was there today for the legislative conference that Every Life Foundation puts on every year. And I'm just excited. And if you see us on social media, please share. But on to today's program, we are excited that Dr. Rohit Aggarwal has come back today after such a very popular episode in January. So one moment, let me add him on. Hey, Dr. Aggarwal, how are
Hi
you doing?
there. Good. Well, thanks a lot for inviting me back again.
Well, we appreciate you taking time. If you've got questions, please put them in the Q&A. This Encore webinar, we wanted to ask the questions that we didn't get to last month. So I pulled the Q&A report from Zoom, and I've got the ones that we did not ask. But if we have time, we will be happy to add some other questions so you can put them in. And if you want in the chat, tell us where you are tuning in from. It's always exciting to see where everybody is at. I am in Columbia, Maryland. And Dr. Aggarwal, where are you
I'm
reaching us?
from Pittsburgh, Pennsylvania.
That's right. Okay, so let's go ahead and go into it. Let's see, our first question is going to be about what are the long-term effects of polymyositis? I have been told that it's curable and IVIG is having a very favorable effect.
Yeah, so I think the medical doctors don't like to use the word curable for autoimmune diseases because the word curable means that the cause of the disease has been removed. Okay. So a word curable would apply to something like infection. You have an infection because there was a bug in your body. The bug got killed by antibiotic, and now you're cured of that infection. Okay. Unless that infection comes back again, you have no reason to be diseased. Okay. But in autoimmune disease, because of the very nature of the disease is autoimmune, that means your own immune system is causing the disease in a way. So we don't like to use the word cure because whatever treatment we give you, we don't get rid of your immune system. And because your immune system is inherently responsible for the disease, we like to use the word treatable rather than curable because that's more appropriate medically, that we treat the disease goes in remission, and that's how we want to treat. Now, polymyositis is definitely treatable. I would say most, but not all, patients get significant relief from various immune suppressive drugs that we use, including IVIG. IVIG is not the only drug. There are various other drugs that we use for polymyositis with significant success in most cases.
What is the occurrence of GERD and dysphagia in IBM?
Very good question. Actually, IBM patients, the frequency of dysphagia is quite high, but there are some patients with only mild dysphagia, moderate and severe dysphagia. Who we worry about the most is those who have moderate to severe dysphagia, because what happens is it leads to aspiration, leads to recurrent infection like aspiration pneumonia, and that leads to actually significant problem. And I have patients who cannot who have significant problem with difficulty in swallowing, where they could have in multiple infections during the year, or sometimes they may even require tube feed. So it is a major problem, but also it's not the most well-studied area in IBM. So we actually brings me to a point, we are actually going to start a research project in IBM to evaluate dysphagia specifically in patients with IBM, because we know that dysphagia exists, but there is no current intervention that is being done for IBM dysphagia, nor we know all the valid reasons why the dysphagia happens. So this is a very intense study. In a way, we will basically evaluate all different modalities with dysphagia. We'll do barium swallow, we will do a questionnaire, we'll do imaging to understand why in IBM patients have dysphagia and what happens to them. So again, obviously many of you are not from Pittsburgh. That's require you to be physically present in Pittsburgh or nearby. It's only one-time visit, but we are going to look into this whole issue of dysphagia in IBM.
When should one be concerned about overlap syndrome?
So overlap syndrome is a very difficult term to explain because basically it has been used in different sense by different doctors and patients. So I'll explain you the two most common use of overlap syndrome. One overlap syndrome is basically you have myositis and you have another disease entity like lupus, rheumatoid arthritis, scleroderma. Since you have two of those, we call you as an overlap syndrome. That means you have this disease and this disease. And that's the most common language that is used for overlap syndrome. But there are other languages that are used. For example, there are antibodies that are associated with overlap syndromes, in which case, if you have myositis with that particular antibody, you may be called as overlap syndrome. So it's other times what can happen is you can be called as overlap syndrome just because you have two different clinical features from two different diseases. So you may not have the full-blown disease, but because you have a clinical feature from lupus and a clinical feature from myositis, then you can also be called as overlap syndrome. So that's why it's a little difficult to explain, because different doctors and people call it differently. There is no well-defined, agreed upon definition of it. But the best definition is when you have two separate rheumatological autoimmune condition, such as myositis plus scleroderma, myositis plus lupus, myositis plus Sjogren's, myositis plus rheumatoid arthritis, any of those two combination, I think is the best way to call it an overlap syndrome.
Thank you. Have you used a combination of Rituximab and IVIG for maintenance for DM to prevent flares and improve muscle weakness?
Yes, but if you're requiring IVIG and rituximab, that means your disease is severe. That means even though that treatment is working, the question is how long are we going to continue IVIG and rituximab? So see, initially our goal is to improve you. So let's say you got IVIG and rituximab and it did help you. But then we have to maintain the disease in remission. It is difficult for me to foresee continuing IVIG and rituximab as a maintenance treatment. Now, I can tell you I have patients who are on IVIG plus rituximab as a maintenance treatment. But my argument or my advice to those patients would be it will be better if you could get your disease control on a long-term basis with additional or alternative medications, or joining clinical trial, because that might be more beneficial for you long-term. Long-term use of IVIG plus rituximab for maintenance of the disease, I think, is little bit problematic, because more and more rituximab, you get more and more B cell depletion and increased risk of infection. IVIG is inherently expensive and difficult treatment to continue. So there are many reasons that I would strongly advise that instead of rituximab and IVIG as a maintenance, try to find alternatives as well. Having said that, there are patients who cannot do anything else, but that's the only thing that works for them.
What is the status of the MINT study for DM-ILD patients, and are all sites currently recruiting?
That's a great question. So actually, we have 11 patients recruited, and they are doing very well. And actually, I have to tell you that patients are the most happy in this study because patients are doing studies from their home, which is, it can't be any more easier for the patient. And we are very happy to see the success of the study, because it was very difficult to set up the study. To do everything from patient home was rather difficult. But now that we have achieved it, I think I would encourage more and more participant to join the study if possible. The study is completely active. We are able to recruit patients from anywhere in the country. You don't need to be near any designated site. You could be anywhere in the country and participate in the study. All you have to do is shoot me an email, and I can send you the Mint phone number and email in the chat. And all you have to do is, send us an email that you're interested, and then we'll get the ball rolling. You don't need to go to a site basically for this study. Everything will be done through near your home.
Do any of the autophagy boosters like ivermectin, hydrochloroquine, and rapamycin prove effective in resolving IBM muscle wasting or CK reduction?
There have been all of these treatment could be tried, maybe tried, but honestly speaking, none of them has any proven outcome. So I would, if you try it, it makes you feel better. If you like it, I have nothing against it. But at least in terms of proof or scientific proof, I would say it's not available. So I have posted the Mint study phone number and email on the chat for everyone to look at.
Thank you very much. What is your experience with rituximab in regards to treating antisynthetase syndrome with ILD, especially in terms of overall infection risk?
Yeah, so see, ILD is a severe manifestation of our disease. So rituximab has been incredibly helpful in treating patients with ILD. Now, I would not say it works on all patients, but it works on many patients. So we use rituximab quite often in ILD, specifically in patients with antisynthetase syndrome. We looked at in our study cohort of rituximab in myositis study, those patients who had antisynthetase syndrome did the best in terms of rituximab, and those who had ILD also had good outcomes. So we definitely use rituximab for ILD. I think where the problem comes is not when the patient gets rituximab and gets better. The problem comes more how to maintain the disease, how to maintain the improvement. And that's where I think the drugs like rituximab and others have some disadvantage, because long term, they may increase risk of infection. So short term, getting the disease better, definitely, I love it. We use it a lot. Long term, also, we have to use it because sometimes we don't find any alternative. But long term increase, as you keep giving rituximab, there is continuing increased risk of infection.
What is the risk to the heart with IBM?
IBM patients, the heart is actually, I wouldn't say least of the problem, but I would say is less of the problem. Most of our patients, when they develop cardiac manifestation is generally very, very late. So I would say heart is, I have personally not had issues with cardiac involvement with IBM as common that I would have with a non-IBM myositis, let's say. So heart could be involved, but it's really late stage. By that time, IBM patient has so many other complications, specifically from respiratory muscle weakness and difficulty in swallowing, lead to recurrent infection. So I have to confess that personally, I've not encountered significant involvement of heart with IBM.
This person has DMPM with chronic muscle pain, weakness, and fatigue with minimal activity. And when they do PT, it induces severe muscle pain, and just wanted to know if you had any recommendations for how to balance that chronic pain with the need for physical therapy to prevent further muscle atrophy.
Yeah, I think that's a great question. So let me first explain you why pain occurs in myositis, because we just got a paper accepted on pain in myositis, because pain is another not well studied area in myositis. And I will tell you, when I was learning in medical school about myositis or in residency, we were told leads to painless weakness, means pain is not part of myositis. That's how most physicians are actually taught. But our research and other research should suggest that that's not true. pain is actually very much present in 2/3 of the patient. 1/3 of the patient can be severe. Another 1/3 is moderate. So it's definitely quite common. But pain comes from, I would say, three, if not more, different aspects of myositis. So let's talk about one by one. One component of pain is related to disease activity, which means patient and muscle inflammation that leads to weakness. Now you have to exert that much amount of pressure on your muscle to maintain the level of activity. That leads to muscle fatigability, muscle pain. Similar to somebody who has ran the marathon, right? So you will have muscle pain, soreness from running the marathon because you're putting a lot more pressure on the muscle for that level of activity. Typically, this type of pain does get better with treatment. As the patient gets stronger, the patient doesn't no longer have to exert that much pressure on the muscle, lead to decrease in the pain. Second type of pain comes from muscle damage. So muscle damage, basically what happens is over the long term of disease activity, some of that inflammation start to turn into damage, fibrosis, atrophy of the muscle. And once the muscle damage hits, then the structure of the muscle, the ultrastructure of the muscle is not the same, right? This sort of led to damage. That damage also lead to chronic pain. So that pain is incredibly difficult to get rid of. Even if your doctor tells you you're normal, you're in remission, but my patients say, wait a minute, but I'm having severe muscle pain. How can I be in remission? Well, that's because your doctor is evaluating inflammation and active muscle inflammation and weakness and saying you're in remission. That means the disease activity is normal, but he or she doesn't have much an ability to detect damage. And that's where you call your pain is coming from in most cases. And the third component of pain is concomitant fibromyalgia. In any autoimmune disease, about 30% of the patients have fibromyalgia. And basically, that could also lead to pain and fatigue. So, first component does get better with treatment. The second, very difficult to get better. And third is where required different line of treatment. Having said that, the only way to mitigate pain is to increase exercise tolerance. And the only way to increase exercise tolerance is by exercise. So in your case, what happens is when you go to exercise, you have pain. So you don't want to do exercise. So you're sort of in a vicious circle, a cycle that leads to more and more problem. You really need to break out of the cycle to do amount of exercise that just cause little soreness but not pain. Doesn't induce severe pain, but you got to get to a level where you start to feel the pain or start to have little soreness, because that would make sure that you've done enough exercise. But then you do it on repeated basis, because muscle memory is very important. Everything is based on how the muscles are developed. You continue to do that for a long period of time, where with each time making small increment. So let's say you're able to do 10 minutes of exercise, okay? And that leads to soreness, but you're okay. In 5-10 minutes, you're fine, and it doesn't cause you a debilitating condition for the next day, okay? You can still function next day. Then I would do 10 minutes every day for next 1 month, 2 months. Next time, then I will say, okay, now I'm going to go to 12 minutes or 15 minutes, depends on your tolerance. Do the same thing for next 1 to 2 months. This is how you could train your muscles to get to the level where you want to be. And that's the only way to do things.
Is it reasonable to switch from IVIG treatment to Imuran if patient's blood work is all in normal range? For the last year, IVIG has been the only treatment.
Yeah, that's a completely reasonable, but I wouldn't say blood work is in the normal range. I would say, how are you feeling? Is your strength good? Is your doctor happy with where you are? You don't have any rashes? How are you? Basically, once the patient is in remission, after a year being in remission, we need to de-escalate the therapy. Everybody talks about going up on treatment. Nobody talks about getting rid of treatment. We are putting a lot of effort in getting rid of treatment, getting patients in remission and getting them off treatment. one of my major goal is how many patients I'm able to get off treatment this year. So because it's much easy for me to give drug, getting off the drug is much harder for the patients and for me. So we have to plan how we de-escalate the therapy, because many patients can stay in remission for years and years and years and may not require another treatment ever. So keeping patients on treatment, I think, is a wrong thing to do, especially on the patients who are doing well. I think the treatment should be tapered off in a very judicious and monitored way.
Do you have patients that, are a little hesitant or nervous to back off, thinking that it might
Yeah.
flare back up? I
See,
mean, how does a person know when they should start to possibly taper?
yeah, I think the issue is these patients have suffered so much that they're very fearful of trying, because whenever you will go off treatment, there is a risk of flare. So you have to balance that fear or that risk versus continuing immune suppression, right? There is a risk in continuing immune suppression as well. So you have to balance, and the way we are able to strike the balance is, again, I don't have the magic number, but we came up with this number that if somebody is in remission without on drug, remission on drug for 1 year, we'll try to get them to a lower dose. If they are remission on low dose or minimal immune suppression for 1 year, we'll then go to remission off treatment. We will watch them like a hawk, so that if they develop any symptoms or blood abnormality, we can quickly jump on it and not let the patient go as far as the patient went last time. So that's the only way to do, very monitored way of cutting down therapy. And I cannot tell you, I mean, I can tell you how many patients I'm able to get them off treatment, and it gives me a strong, actually, it gives you a lot of happiness to tell the patient that you don't need to see me anymore, because that's a good thing.
Mhm. We had a question come in about that specifically. Do you take patients off of Plaquenil when they are doing well? This person has been off
I
everything for 4 years, but they're still on Plaquenil.
Well, my goal is to get them off remission of treatment. So I will eventually also take people off plaque.
Okay. This person would
Myositis
like
is
to go ahead.
myositis is not like lupus. In lupus
Mhm.
patient, I will never take them off plaque. But myositis is not like lupus, and many patients go in long-term remission without any flare-up for years and years and may never have flare-up.
Can DM cause panniculitis, and will a higher dosage of methotrexate be needed for that?
Yes, rarely DM can cause panniculitis. Actually, recently I had a patient, strange enough, because normally panniculitis is a severe manifestation and it happens when the patient have active disease. But this patient had panniculitis when everything else was great. So really surprised us and took us by surprise. But anyway, it's still a part of disease activity and requires significant immune suppression, including methotrexate.
Does DM have to be active for muscle biopsy to be positive, or would it always be positive in the disease?
Okay, sorry, I did not. DM has to be?
DM, does
Has
DM have to be active for the muscle biopsy to be positive?
Oh, that's a great question. Yes, if you biopsy a muscle with inactive disease, it will be difficult for your pathologist to show that there was a disease or there is a disease. Yes, definitely. We do not biopsy patient when they are in remission or they're doing well, because we don't see much of a value in doing that. But we always biopsy patient when they are in active disease or have flare up.
With DM and the TIF1Y antibody, how important is a PET scan as a screening tool? This person, the insurance is denied even with an appeal, and so they want to know, are there other means of obtaining a PET scan, such as through a research hospital? And are there any upcoming studies involving DM and
Yeah,
TIF1Y?
do you know the age of the person?
I
No. Okay.
don't, and let me see if
So
they are on.
basically, TIF1 gamma antibody with DM has highest risk of malignancy or cancer. Now, what happens is the reality.
Okay. Dr. Aggarwal is frozen. One moment, everyone. Hopefully he will come back. All right. We lost Dr. Aggarwal, but I am sure he will log back in shortly. Thank you for your patience. We are doing good on time. And so we will be able to, it looks like we will be able to get to the questions in the chat. I mean, in the Q&A. Here he is.
Sorry, I don't know what happened. I got disconnected. So I don't know where I was because I kept speaking.
Well, I had a little bit of an anxiety attack, so I don't remember where you were either. No, I'm kidding. We
Okay.
were talking about PET scans.
Okay,
This
yeah.
person has the TIF.
Yeah. So I was
1.
asking, do you know if the age of the person?
I don't, and they
Oh,
aren't on this particular call.
okay. So basically, the TIF1 gamma antibody has two phenotype. One is less than 40 years of age. If you have a DM with TIF1 gamma antibody in less than 40 years of age, you don't have to worry about cancer much. But if you're above 50 years of age, then it becomes high likelihood of cancer. So we recommend PET scan only with TIF1 gamma with DM above 50 years of age. But if you cannot get the PET scan done, then we recommend comprehensive screening, which include at least a CT scan of chest, abdomen, and pelvis.
Mhm.
All the basic labs, endoscopies, cancer tumor markers, extensive labs
Mhm.
if you can't get the PET scan. So either you just do a PET scan because that'll be one-stop shop kind of thing, or you have to do CT scan, chest, abdomen, and pelvis, multiple labs, endoscopies, and a lot of those things.
Okay, so we had another IVIG question about their treatments, whether they should do it monthly or weekly.
Good question. IVIG treatment is preferred to be done monthly
Okay, why
because
is it that some people do it weekly?
yeah, so the thing is, if you look at the proof or of IVIG working, it's done with a monthly infusion. Now, whether weekly would work, yes, it could work, but it's still a lot of effort to get some infusion every week. So once a month works and it's been proven, so it's much more convenient for the patient to do IVIG once a month. It is possible that weekly works, but we don't have much of a proof or data.
Where does IMNM come from?
Good question. IMNM is immune-mediated necrotizing myopathy, and this used to be this is a part of myositis which was previously thought to be polymyositis, but now it is recognized as its own entity. In this, what happens for some reason that is beyond our understanding is the patient develop acute necrosis of the muscle. That's why it's called immune-mediated necrotizing myopathy. Acute death of the muscle. Necrosis means death of the muscle. And what happens is in these patients, they develop this acute death of the muscle fibers rather acutely. So they all of a sudden loses a lot of muscle mass, muscle fibers in a very quick span of time that leads to very high CK level, severe weakness. And if they are not treated quickly, it can lead to disability and muscle damage rather quickly. So what is the underlying cause of INMN? We don't know. We know it's an autoimmune disease. We know it's an autoimmune cause, but we don't really know the mechanism of action of this entity. Although we have belief that patients with SRP antibody and anti-HMG-CR antibody, these antibodies has a role to play in the pathogenesis.
The anti-KU antibody is more recently defined and a rare one. If someone has that marker, what should they anticipate the diagnosis and progression will look like?
Actually, it turns out this KU antibody is an overlap antibody. What does that mean? Well, these patients have much likelihood to have myositis along with scleroderma. So, those who have this antibody have higher frequency of interstitial lung disease. But overall, the outcomes of patients with overlap syndrome is actually quite favorable. So it's actually not a bad antibody, but essentially, in terms of prognosis and what to look for, I think you should look for if you don't have any clinical feature of scleroderma, because it can be seen in patients with scleroderma as well. Because if you do have scleroderma clinical feature, then you may require additional intervention and diagnostic workup.
This person has classic symptoms of DM. However, their muscle biopsy was non-diagnostic / negative, and they want to know, should they repeat the biopsy or just proceed with treatment?
If you have classic features of muscle, of skin, I don't think you need to repeat the biopsy. And biopsy is negative because it could be patchy, inflammation is patchy, and just happened where you got the biopsy, it wasn't the right area or wasn't the most abnormal area. So that's why it's negative or inconclusive. I would make sure that your doctor is convinced about DM rashes. And if there are DM rashes, then I don't think you need a repeat biopsy. You should proceed with treatment.
Okay. What
However,
clinical
doing
trial?
However, doing MRI, EMG, or myositis antibodies would be helpful.
What clinical trials are promising for IBM, and how soon will we know about result?
The only one that is really, really promising is Epcuro clinical trial. You may have heard it before. Epcuro has a drug which targets very, very toxic T cell, which is a certain type of immune cell in our body, which is supposed to be toxic to fight infections and other bugs, but in an autoimmune condition can be turned against our own cells. And in this case, it turns against muscle, leading to muscle death, then leading to further problems with IBM cases. So this drug blocks that highly toxic T cell. Hopefully that will prevent the disease. That's the hope here. But the trial name is Abcuro, ABCURO.
Does having muscle weakness and or damage lead to bone not building correctly or osteoporosis?
Yeah, osteoporosis and osteopenia is problematic in myositis for two reasons. One is because our patients are on high doses of steroid for long terms of steroid. So steroid leads to damage in the bones, lead to osteoporosis and osteopenia. The other reason is patient with myositis is a muscle weakness. And the only way to build muscle is exercise and activity. And patients with myositis obviously have decreased level of exercise and activity, leading to further bone loss or damage. So those two reasons, because of those two reasons, osteoporosis and osteopenia should be screened in myositis patient and treated if it's the case.
Does osteoporosis happen even if you exercise a lot?
It can happen because there are many reasons for osteoporosis. All with exercise, you're building the bone, but if the bone losing aspects are higher, then you're going to still develop osteoporosis.
Okay, how long does CellCept take to start working?
About 6 to 8 weeks.
Okay, that is it for our questions from the last one. I'm so excited. We still have a few in the Q&A though, and then we will give you back your time. Let's see. Are you aware of any myositis patients who also have ILD who have taken the oral therapy Seracatinib?
Say that again.
Are you aware of any myositis patients who have ILD who have taken the oral therapy Seracatinib. This is the first time I've heard this.
SERA?
It's Saracatinib.
Okay. No, I do not know any myositis ILD patient. This drug is being studied in idiopathic pulmonary fibrosis, but not in myositis ILD yet.
Okay. Is it okay for IBM patients to take a statin for cholesterol reduction? And if not, is Repatha a good alternative?
Excellent question. It is okay for patients with myositis to take statin if they do not have immune-mediated necrotizing myopathy from HMGCR antibody. So taking statin is not a problem for myositis patient. You only have to make sure you monitor the CK level before the statin and then monitor the CK level after the statin. Otherwise, any patient with myositis can be on statin. The only patient who cannot take myositis is those who have anti-HMGCR antibody. Second question is Repatha good? Repatha is good, is including those who have anti-HMGCR antibody.
Is there a correlation between having oral lichen planus and dermatomyositis?
I mean, not sure, honestly. I don't want to give a wrong answer, but I have not seen that personally. I think, well, maybe one of my patients did have that, but other than that, I do not recall this combination.
You had DM patients that have more severe GERD and GI dysmotility.
Well, yeah, I mean, many DM patients have severe GERD and GI dysmotility because you know that the myositis affect the swallowing apparatus. So that leads to GERD and GI dysmotility because upper part of our swallowing apparatus, when we swallow food, the upper part of it is made up of the same type of muscle as our shoulders and hips. So basically, in myositis, those muscles are affected, and that also leads to the effect on difficulty in swallowing because of the type of muscle for upper part of swallowing apparatus is the same as we get weakness in arms and shoulders.
All right. Well, thank you so much for taking time out of your busy schedule to meet with us today. We really appreciate you. And we are so happy to celebrate Rare Disease Week with you to kick off this week. And did you have any last minute words you would like to share?
Yeah, I think I would like to share that those who are listening, if you could, tell your colleagues or your friends who have, because, many of you are in the groups in myositis, tell people about the MINT trial because we are now actively recruiting those who have myositis and ILD could possibly be eligible for the study. So I make a personal appeal for the MINT trial for patients who may not have even ILD, but those who know patients who have ILD, please recommend the trial and have them contact us. It's a great trial to be part of.
All right. Well, thank you so much. And I have put the Mint information back in the bottom of the chat so people could easily access it. So
I think
if
I
you
just
have,
want to answer this question. Diane said, who should not take statin? The patient did not understand. Anybody can take statin except if you have an antibody called anti-HMGCR antibody. If you have this antibody, then you should not take statin.
all right. Well, thank you again. And do you have any words about GCOM? Are you going to be there? It's right
Yeah,
here in your home.
yeah, I know. So we're very excited to actually have TMA come to GCOM. I know you're going to be speaking on the opening session. TMA will be speaking on the opening session, but we are very excited to have this global conference on myositis or GCOM in Pittsburgh from 13th to 16th of March, and almost up to 400 delegates across the world who are researchers and doctors in myositis are coming to Pittsburgh myositis. So we are very excited to have that.
Oh, well, thank you. Okay, everybody have a wonderful evening and we
Thank
will
you.
see you at our next webinar. Thank you.
Thank you.